Okay, so the FDA approved the Pfizer vaccine for ages 12 through 15 a few days ago, but I was waiting for this meeting to make this video because this is the meeting where they present the data, and this is the meeting of the Advisory Committee on Immunization Practices of the CDC, so the ACIP, and so that was done earlier this morning. And these are the slides from the meeting. I'll link this website if you want to go check it out yourself. I perused most of these, and there's 4 of them that are interesting, and that is the safety, immunogenicity, and efficacy of the Pfizer vaccine in persons aged 12 to 15, and then the evidence to recommend this in these adolescents. We'll talk about that in this video, and then there's another slide set about COVID vaccine effectiveness studies in the real world, as well as update on emerging SARS-CoV variants and vaccination considerations. So that'll be in another video. So let's tackle these first 2. So here's the first one. This is the study on 12 to 15-year-olds of the Pfizer Biontech vaccine. So what they did is they basically did an extension of the original study protocol that was done in adults, and that's in one of my previous videos if you want to go look at that. So they just extended this to 12 to 15-year-olds. And so the data from dose 1 to 1 month post dose 2, so everyone had at least 1 month of follow-up after the second dose. And some of them had longer, but at least 1 month. So it's not a long follow-up period. So here's the schema. So you get 2 shots, 21 days apart, and then they follow up for at least a month. And they plan on following for up to 2 years. And then they are going to look at reactogenicity. And so they're going to measure antibody titers 7 days after the second dose, and then look for serious side effects and also vaccine efficacy. So here is so they had previously done the study on 16 to 25-year-olds. That's why it was extended to 16 years and up. And that was like a month ago. And now they're doing 12 to 15 years. So they had a study before where they had about 4,000 participants, about 2,000 in each group in the 16 to 25 year. And then in the 12 to 15 year age group, they had about 1,000 in each arm, 1,100 in each arm. So about 2,200 total. So fairly even distribution between male and female, predominantly white, a little disproportionately large number of Asians in the study population. And less of other populations. The 12 to 15-year-old study was all done in the USA, so 100%. Then these are reactions. So local reactions, you see very little of this other than pain at injection site. All of you that have gotten the vaccine, you know that this happens. Like almost everyone gets some pain at the injection site. Mine was pretty bad. It's hard to use my arm for a day afterward. And some people, it's not quite that bad. And then in terms of systemic side effects, what's a little bit different about this is that between dose 1 and dose 2, there wasn't a huge difference. In the other adult study, the second dose was much higher rates of these systemic side effects. So the biggest being fatigue, headache, muscle pain. So fatigue, headache, muscle pain, about 60% total of these, with a small percentage being severe. Severe meaning that you couldn't do regular activities of the day. You couldn't work. You couldn't go to school because it was so bad. So it looks like there was like 2 to 3% of the severe category in both doses, a little bit higher of the severe in the second dose. So those are the gray boxes. All right, so let's keep going. So adverse effects. So there's slightly higher adverse effects with the vaccine over placebo. That's to be expected. In terms of any side effects, it's pretty much the same. Related side effects, a little bit higher. Okay, so this is more adverse side effects data. So nothing really exciting here. Very, very low side effects. I mean, they had 10 events in the vaccine group, 8 events out of, this is out of 10 out of a thousand, so that's 1%, and 8 out of 1,000, that's like 0.1%. So like 0.02% difference between the placebo and the vaccine group. So these are very low side effect profiles. They did notice that lymphadenopathy was one that they thought was related. So they had a 0.8% in the vaccine group and 0.2% in the placebo group. And so they had lymphadenopathy that was usually in the axilla or the neck, so armpit or neck. And that's probably related to the reaction of your immune system to the vaccine, which makes sense. Okay, so this is something that's a little bit interesting. So serious adverse side effects. So these are, what they consider to be serious. I don't know what the criteria for serious being, but this is the vaccine group and this is the placebo group. So they had 5 serious adverse side effects in the vaccine group and 2 in the placebo group. This is 5 out of 1,131 and 2 out of 1,129. So very low rates. What's interesting, they had one patient with abdominal pain and constipation, and then they had one patient with appendicitis and focal peritonitis in the placebo group. I mean, this probably just happened. These are things that just happened during the course of the 2-3 month study. Some people, a certain percentage of people, if you just watch 2,000 people, a certain percentage of them are going to have severe abdominal pain or peritonitis or appendicitis. There was 4 incidents of psychiatric problems, depression, anxiety, suicidal ideation. They were all in the placebo group. It's hard to say that was caused by the vaccine. The numbers are so low, you can't. If you run the statistics on it, it's not clear that this is just happened to pan out this way because it's just such low numbers. Because there's no reason to suspect that the mRNA vaccine would cause any psychiatric disorders. So it's just possible that in an adolescent group, there happened to be a few that were depressed or had anxiety, and they just happened by chance to be in the vaccine group. There is a small possibility that there's some contributing factor to the vaccine on that. So no deaths during the study. That's good to know. Yeah, so when you look at these, someone could present this and say, "Oh my goodness, there was this like 100% psychiatric disorders rate in the vaccine group," but with numbers this small, you can't make those kinds of conclusions. Okay, yeah. So this is where they measured the neutralization assay. So how many neutralizing antibodies did they have? On day 1, they had this, and then day 2. So day 1 after the second dose, and day 52 post 1 month after the second dose. 1 month after the second dose. So quite a bit higher. In the placebo, obviously no change. And then in the 16 to 25-year-olds, they had a big change. But you notice that the geometric mean titer is higher in the younger kids. This kind of goes along with the previous paper that talked about how small children generate pretty robust immune responses even with mild or asymptomatic disease because their immune systems are just better and more responsive. And so they show that that there is non-inferiority, so which means they did better than even the 16 to 25-year-olds. So that's good. So it means that the kids definitely react to the vaccine, and they definitely make an immune response and antibodies in response to the vaccine. So the vaccine works in the kids in generating a response. Now the question is, does it work in preventing them from getting disease? Again, this uses the protocol from the adult studies, which means that they did not look at asymptomatic disease. They waited for symptomatic disease. So it is basically how effective is it in preventing symptomatic disease. And so here's the endpoints. So there were 0 patients in the vaccine study in the follow-up period that had that got symptomatic disease, and 18 in the placebo. So their vaccine efficiency is 100, but because of the follow-up time being so low and the numbers being relatively low, remember in the full adult study they had 40,000 participants, so they had a much tighter confidence interval. The confidence interval is it could be anywhere from 78 to 100% vaccine efficacy. More than likely, the vaccine efficacy in children is about the same as in the adult, or maybe slightly better. So, it's probably in the 90s for the wild type variant. Okay, so the second study, the second presentation basically looked at what kind of thought process did the CDC and the ACIP go through to recommend the vaccine in adolescents aged 12 to 15. So basically what they want to know is, what are the pros of giving these kids the vaccine, and what are the risks of giving them the vaccine, and do the benefits outweigh the risks in this population? So in older people, it's pretty clear that getting the vaccine is a good idea, because older people have a very high rate of complications, relatively high rate of death from COVID, and the risks of the vaccine are very low. But vaccine, again, is not a zero risk proposition. In children, the math is a little different, because children do very well with COVID, and so their risk of complication from COVID is extremely low, and the risk of death from COVID is extremely low, and then the risk of bad things from the vaccine is also very low. So you basically have low benefit, low risk. So at that point, which way are you going to go with them? So this is their this is a presentation about their thought process. So should vaccination with this Pfizer Biontech vaccine be recommended for these people? And so what they're comparing it is, do they give them the vaccine? The comparison is no vaccine. And what do they care about? Symptomatic so does it prevent them from getting disease? Does it prevent them from getting hospitalized due to the COVID? Does it prevent multi-system inflammatory syndrome in children? Because this is something, MISC, this is something that happened in children because they have such a robust immune response. Some of them had a really, really bad inflammatory response, and kids got really sick from it. And this happens often in adolescents as well. Do they seroconvert to a non-spike protein? Does it prevent asymptomatic infection? Are there serious adverse side effects? And did they have? I don't know what the reactogenicity grade 3. I wonder if that's talking about side effects or not. Okay. Anyways, let's go through this and figure it out. Okay. So the evidence to recommend framework. So is the problem of public health importance? How well does the vaccine work? What are the desirable side effects, and how substantial are them? How substantial are the undesirable anticipated side effects? And then, does the risks outweigh do the benefits outweigh the risks? Does the target population feel the desirable effects are large relative to the undesirable effects? So again, risk-benefit analysis. Okay. So this is what they're wondering. Are the consequences of COVID-19 serious? Is it urgent? Like, is this a problem that we need to deal with now, or can we just kick it down the road? Are large numbers of adolescents affected by COVID-19? Are their population disproportionately affected by COVID-19? Okay, so they're going to present the evidence on this. Here's the trends in COVID-19 cases over the past year. And so, it started back, for our first cases were kind of March, February that we knew about. Then it kind of spiked up. Then we had a spike in the summer. And then we had that huge spike over the holidays. And then it's kind of trending down, fortunately. So we're kind of in this region. And then this is the trends in the 12 to 17 age group. Fairly similar. They also got the big trend. And what you'll notice is the overall trend, we've gone down to kind of like the July levels. In the adolescents, you see that we are above the July levels from last year. This is because most likely the older populations have been vaccinated. They're less of a proportion of this, and the adolescents are a larger proportion of the COVID cases. Okay, so that's what you see here. You see that in the younger age groups, they used to be a small proportion. Now they're, probably 18% of the proportion of the population. So they're becoming a larger fraction of the groups that are getting it, which makes sense, probably because of vaccination. They're estimating, so they don't test everyone, and a lot of people are asymptomatic. So this is a mathematical construct. It's an estimate. These are not like actual numbers, but it's based on their best data they have and the best models they have. And so they figure that there have been about 22 million SARS-CoV infections in 5 to 17-year-olds. And they have, this is a little bit surprising data, because I would have thought that there would be more not asymptomatic infections in the 5 to 17-year-olds, but according to this, they're saying that the majority of them are symptomatic, probably just mildly symptomatic. All right, so cumulative age groups. These are hospitalization data. So you see that hospitalization is rising a little bit more recently. But I mean, if you look at the scale here, it's very low. It's like 1 per 100,000, 2 per 100,000. So these are very low hospitalization rates. But it is a slight uptick. They're comparing this to the H1N1 flu and influenza flu in 2009. So here's influenza hospitalization rates per 100,000. And then you see COVID. So they're just basically saying this is worse than the H1N1 influenza of 2009, 2010. Looks like about twice as bad. Okay. Then, as in adults, kids that have pre-existing conditions or underlying comorbidities have a much higher hospitalization rate. I think I saw here someplace. Yeah. So at least one underlying condition, 61%. So 61% of all the kids that have been hospitalized have some underlying condition. The two most common being obesity and asthma. All right, here's the COVID death numbers. So initially, so you see that the death numbers, we are getting better at treating them, because remember, initially the death numbers were pretty high, but the case numbers were pretty low. And so even when we had this huge spike in over the holidays, our death rates didn't go that much higher than the initial rates, even though the case rates were much higher. So we are getting better at treating this thing. So the trends are low. That's a good sign. Okay, so they have 127 COVID deaths in America out of, if you do the math, they estimate, I think it was 22 million infections. So that's 5 to 17. And so this is a slightly different group, 12 to 17. So 127. If you go from 5 to 17, it looks like it adds, maybe just eyeballing it, 60 more, so 180. Let's do the math. No, sorry, wrong one. Calculator. So if we say it's about 180 divided by 22 million, that is a death rate of 0. So 8 in a million. Yeah, about 8 in a million. So very low, extremely low. So out of every 1 million kids that were infected, 8 of them died. So the MISC, this is a little bit of something new to me because I thought that this affected younger kids more, but it looks like that actually adolescents have more severe disease. This is where it comes down to probably why they're recommending it, is because adolescents transmit disease. And so they are more likely to be infected, and then they can transmit it to other people. Because these are talking about how they do it. And so you see that in kids that are going to school, the chances that they're going to transmit it to the adults in their household are an odds ratio of 1.5, so which is about 50%, 40 to 50% higher. So basically, they're saying that you can get severe disease. I mean, the rates aren't high, but it is possible, and there is death from it. It's very low, but it is also possible. So they've concluded that it is of public health importance. The efficacy was 100%. Remember, they say a high degree of evidence. That's true, but the confidence intervals were pretty wide, 78 to 100%. And if you were to guess, it's probably the same as the adult studies, which is like mid to low 90% efficacy. Geometric mean ratio was better, 1.76, so that means they do respond. They had no hospitalizations. Again, small number, so you can't read too much into that. They only had 18 events in the placebo group to compare it against. So serious adverse events were these. This is talking about the abdominal pain and the psychiatric side effects. They say very low certainty of evidence. That is true. Those numbers are extremely low. So it's hard to say that, number one, that it's causal, and number two, that it wasn't just random distribution. Okay, so severe reactions. I think this is what they're talking about, the grade 3 reactogenicity. So it is higher. So 11% had severe reactions. So 11% of vaccinations result in severe reactions, probably headaches, fatigue, muscle aches, to the point that it interfered with school or work, versus 2%. So there's about a 8 to 9% difference. So that's very true. They had pretty high, big numbers on this. So I would say this is very high certainty of evidence. So no deaths. That's good. Local reactions occurred in everyone. And then systemic reactions, fatigue and headache, just like we talked about in the previous slide set, or the most common. Severe effects that kept people from going to work or going to school was 10%. No cases of Bell's palsy or facial paralysis. They mentioned this because there was some talk of that being an issue in the full adult studies. There are a couple of patients that had Bell's palsy in the little bit more in the vaccine group than in the placebo group. Hasn't panned out in the other age groups, so that was probably just coincidence as well. So they think that it is going to be effective. So you are going to prevent people from getting it and prevent people from transmitting it, and then the harms are small. So they decide that they favor the intervention. Okay, so I guess when they surveyed the kids, parents, a little more than half of parents plan to get their children vaccinated. The ones that were not sure, they were worried about safety. So short-term safety, I think we can say with high confidence that it is very safe. Long-term, of course, we don't know, but as we talked about in the previous studies about the mRNA vaccines, there's no scientific reasoned or or mechanistic reason to suspect that there's going to be any kind of long-term side effects. It's not going to cause infertility. It's not going to change your genome. Of course, you don't know what you don't know, but from what we do know, it should be very safe. And now we know that millions of people have been vaccinated with the mRNA vaccine, and these vaccinations started, 4 or 5 months ago, and they've been monitoring any side effects very closely. And that's why they picked up on the clotting. The clotting was an extremely rare event. They still picked up on it. I think that's reassuring. They think the vaccine's developed too quickly. This vaccine was developed very quickly, but it basically built on a lot of science that had been going on for years. They don't trust information being published about the vaccine. Well, what can you do about that? If you can't trust it, then, there's nothing that will make people trust information studies if they're not going to trust it. They feel like they don't have enough information. If you don't have enough information, I guess it's pretty easy to get more information, and they're just waiting. These are reasonable concerns, and I think these parents are trying to do the right thing. All right. Okay, these are more this less interesting information. Can they do it? Resource use. Okay. All right. Well, I think the bottom line is the vaccine studies that they reported shows that there is extremely low rates of problems with the vaccine. There's a 10% severe reaction rate in terms of headache, fatigue. These are temporary, last about a day or two. Very similar to adults. The children do generate good good responses, and it is very effective. 100% effective. Of course, the confidence interval is between 78 and 100, most likely in the mid to low 90s. That being said, this age group does very well. They have extremely low rates of hospitalization and extremely low rates of death. So if you punch the numbers through, the risk and the benefits are very low on both ends. So I think if you want to be completely objective about it, in terms of the kids, protecting the kids themselves, it's probably a wash. You're probably fine either way. The needle probably tilts towards getting vaccinated because the risk of vaccine is lower. It's extremely low. It's way lower than the risk of actual COVID infection. But the risk of COVID infection of bad outcomes from that are also low. But the chances of a bad outcome from the COVID vaccine is extremely low. And people that are worried about the long-term side effects of the vaccine, we also don't know the long-term side effects of COVID infection. So, there may be long-term side effects of COVID infection. So that's the other, the flip side of the coin to think about. My adolescents, both of my adolescents are probably going to, my older one's already vaccinated, the young one's probably getting vaccinated. The other thing that people need to consider is basically getting the kids vaccinated is kind of an altruistic thing because it protects the other, like there's certain kids that have transplants and are immunocompromised or have other comorbidities that make it so they can't get vaccinated. They are depending on the healthy kids around them getting vaccinated to protect them. So in terms of getting vaccinated to help the people around them, if they're going back to school, that's probably yet another reason to get vaccinated. So I think we can say that it's very safe, but the flip side of the coin is COVID-19 is not very severe in this age group as well. So the risk-benefit profile is not nearly as good as in older patients. Like if you're in the older age group, the the balance swings way in favor of getting the vaccine. I think in this case, it does swing in favor of the vaccine, even on an individual level. And then when you consider kind of the community stance of protecting those around them, then it swings even farther into getting the vaccine. Okay, so we'll talk about those two other slide sets in another video because I think this one's long enough. But I think the other two slide sets are actually very interesting. Real world studies on vaccine effectiveness are discussed, as well as the effect of the variants.